Hi everyone, I think we'll make a start now. I'd just like to welcome everybody to the first in our new webinar series, which is a collaboration between Sheffield Hallam University's CPD Anywhere and the Journal of Radiotherapy in Practice. Our first speakers this week are going to talk about their paper that's in the JRP, which hopefully you've had a chance to read, on their audit on head and neck cancer and the impact of weight loss. I'm just going to explain very briefly about the format for this evening. So, as I've mentioned already, if you were here earlier, I've disabled the audio and video of for everybody so that we don't get too much feedback from too many people's audio being on. So what I would like you to do is, while our speakers are talking, if you've got any questions, what I'd like you to do is just type them into this into the chat box, which, if you've never been in a chat room before, is just should be on the left-hand side, the bottom left-hand side of your screen. So you can just type in there anytime you have any questions, and what we'll do is the speakers will speak for roughly around 20-25 minutes, and then there'll be plenty of time at the end for questions. And what I will do is I will try to collate any questions, and I will pose those to the authors of the paper on your behalf. And they may want to open up the floor to a bit of a debate as well. So we'll see how things go. So is that okay with everybody? If you can give me a hands up or a thumbs up or an indication in the chat box that everybody's happy. And what I will do is I will switch over to Amy and Patrick, who are going to do the presentation, and I'm going to switch off my video and my audio now. So I'd just like to welcome now Amy, Taylor and Patrick, who are the authors of this paper, and we're really delighted that they're doing this for us in our first webinar session. Thanks, Amy.
So, hello everyone. Can you just indicate as well if you can hear me and Patrick, if that's okay, so you could just type in for us. Yeah, that's if you look like. Right, so good evening and welcome. So this is obviously Amy Taylor and this is Patrick Dawson, and we'd like to welcome you to this evening's webinar. What we're doing is discussing a project that we did, which was exploring the risk factors for weight loss in head and neck cancer patients. Obviously, if there's anything as you go through that you can't hear anything, just let us know, and Heidi can pick it up and identify this to us. So again, thank you and welcome for coming. What I'd like to do first off, just give a little bit of background about head and neck cancers. They are obviously very prominent, over 9,000 diagnoses per year in England. This has been steadily rising since around 2002, and we've reached this figure since around 2009. We know that radiotherapy is used in conjunction with surgery and chemotherapy, creating like a multimodality approach for these patients. And this often makes the treatment, the side effects more severe, and the management of these side effects much more complex. We know that weight loss can actually begin as a symptom as part of the cancer diagnosis. It can occur through the other treatments that we've received as part of the journey, and obviously then radiotherapy and the adverse effects that we can cause. What we are noticing is that if these patients are beginning to lose weight, that there can be a change in their patient console, either through physical weight loss or through like a reduction in tissue volume or swelling, and this may lead to these patients being required to be replanned during the radiotherapy treatment. We also know that there's a lot of evidence to suggest that malnourishment can lead to a reduced quality of life for these patients and lower overall survival. As we know that these patients with the advent of HPV are becoming younger at the time of diagnosis, so this is something that we need to be limiting, that they are obviously suffering from more severe and more adverse effects. So the Audit itself was undertaken as part of a collaborative project between Sheffield Hallam University and Sheffield Teaching Hospitals, and it was part of a bigger project which is still undergoing at the present time, but obviously the results of this will be released once data collection is finished. And what we are doing as an overall project is looking at the assessment and impact of volumetric changes of patients undergoing rapid arc radiotherapy for head and neck cancers. The purpose of this overarching kind of project came about when we started at Western Park treating patients from 2012 with rapid arc, and so this was rolled out to all head and neck patients. Originally they was treated with a three-phase technique, a conformal technique, and we'd always monitored kind of anecdotally more so any weight loss or tissue volume changes through recording of SSDs and looking at their mobilisation shell to see if there was any gaps. So this was very kind of radiographer specific to notice and identify, and if the patients themselves were recording and reporting that they were noticing that they were losing weight. What we did want to do is make sure that any weight loss didn't influence a change in more than 2%, either affecting like a dosimetric change on either the PTV or any organs at risk around kind of proximity to the PTV. So this was kind of closely monitored. Now, however, obviously with IGRT and CBCT and XVI capabilities that we've got on these treatment machines, we're actually being able to visually see this on a daily basis through the pre-treatment imaging or, following weekly protocols. So obviously this falls in line with the on-target recommendations. With us now having this volumetric data that we could get from the CBCTs and XVI, it provides a volumetric record so we can logically track any patient changes as we're going through the treatment regime, whereas before it was, like I say, very anecdotal and we had to kind of record and notice and pick it up ourselves. Whereas now we can go back and look and monitor how much weight patients are losing, how much shape change, and again take this back to the dosimetric impact of it. So originally, to account for this, what we did was we notified the planning team and physics department, and they would modify the monitor units of any fields that were in a direct beam pathway of the area where the patients had experienced weight. And so this is obviously accounting for the change in the depth of tissue these patients were experiencing. What we have found now with the implementation of rapid arc is these guidelines are no longer clinically transferable. So we were looking at a way to, one, monitor how much weight loss these patients were experiencing, but also to see if it's what we can be doing to correct for this. So now we've got the CBCT data available, we've decided to do a kind of more comprehensive clinical audit, and obviously this forms part of this. So with that in mind, the kind of overarching objectives were to look at whether these patients were actually losing weight, or was the change and the move to rapid arc, was it still having the same kind of effect on patient side effects, and were they therefore losing the same kind of volume of weight as what they were using before. And we were looking at this through kind of the records that we keep as part of the daily referral and dietetic and clinic review process. We also want to look if there's any correlation between the onset delta correction, so your changes in position that you're making from your pre-treatment images, and the area where any kind of volumetric shape changes occurred. So we've gone back and done a retrospective review of all the positional changes of patients, and we've also using a technique which is part of variants called Smart Adapt, where it can kind of re-volume and recreate and reformulate any weight loss and create a new volume for that patient. We also wanted to look if this is any changes, are these having any dose impact upon organs at risk and the planning target volume as well. So like I say, we're at this stage now where we're gathering this data, and so we want to see if these changes occurring, are they clinically significant, and do we need to develop a strategy for this. kind of secondary to this is we wanted to identify if there's any predictive factors for patients. So is there a kind of specific type of patient that may, we may find are losing more weight during the radiotherapy treatment. So this is kind of a key aim of this project. It was almost like a two-pronged attack. So what we could do is we could identify, monitor and address if patients are losing weight, what's the dosimetric impact of it, and what can we do to correct for it, and also can we assess which patients might be at a higher risk of losing weight, and if we do find this out, can we kind of create like some preventative measures to put in place to stop those high-risk patients losing weight. So to look at achieving this, we did a retrospective study using 40 patients. This was undertaken at Western Park, and we were granted permission by Sheffield Teaching Hospitals to undertake this work. So patient data was collected from patient notes, so the data was readily available or ready for us to go back to it. We say semi-randomly because we wanted to get kind of an equal balance of gender, so male and female patients, to actually assess if there was any correlation between male and female, whether one was more at risk of losing weight. So the patient's eligibility criteria, they had to be diagnosed with primary head and neck cancer, they had to have had the weight monitored through radiotherapy, which is standard practice, and they also needed to have a curative intent using VMAT or rapid ARC, and a dose of 60 to 70 gray over a course of 6 to 7 weeks. As I say, the data was gathered from medical records, and this kind of caused its own problems, which we'll go through in a little while. So we wanted to look at patient disease and treatment characteristics and identify if there's any variables within these that are indicative that these patients might be at a higher risk to experience weight loss. So we devised a data collection form, and what we wanted to do was gather information about the patients themselves and their background. We went with some of the more standard kind of things that you would think about as being indicative, so stage and grade, smoking and this kind of element, but also some more kind of unheard of, so there are any like lifestyle factors, things like marital status, so have you got support at home, is there someone there? And what we wanted to do is see if any of these had a positive correlation. So we developed this original form and we trialled it out between us. So to reduce any kind of bias and intra-observer variability, what we did was we collected data for the first 5 patients independently, and we got together, compared the results that each of us found, and compared the data to make sure that one, the tool was working, and that 2 we were kind of coming up with the same findings based on the independent notes. What it did highlight to us was that we were finding a lot of the notes kind of had more or less detail within them, and so what we did was we modified the form, and sometimes we needed more information about one certain aspect and less about another. So we developed this new form, and after that we tested independently every 10th patient to make sure again that we were reducing any bias and making sure the results were consistent. We did have some issues, like I say, about the availability of data. This varied from patient to patient, from consultant to consultant, and how much information they were recording in the patient notes. And what we were finding was that things like smoking and drinking, the doctors or consultants or the health professionals were recording very generic information like light smoker, moderate smoker, light drinker, moderate drinker, rather than pack histories and volumes. So we needed a little bit more kind of information on this, so that made some of the results a little bit difficult to investigate. So I'll hand you over to Patrick, who's going to go into more detail about the study itself.
Okay, so I'm going to go for the next few slides. So again, just give me a thumbs up or something if you can hear me.
Can you hear okay?
Can you hear me all right?
Yes,
Smashing.
thank you.
Okay, so yeah, basically just going through the protocol first of all at Western part. Head and neck patients are basically looked after. They're weighed on the first day of treatment and once weekly thereafter. So as a measure of health that can be kept on top of, and people are aware of what's going on with them. They're also referred to dietetic services for weekly review for counselling advice and supplements where necessary. In addition to this, any patients who lose over 10% of their body weight are admitted for closer monitoring and management of their condition. Weight loss itself has been used as a surrogate for malnutrition. National Institute for Clinical Excellence suggests that unintentional weight loss of greater than 5% of your body weight over 3 to 6 months is indicative of malnutrition. However, several studies use the figure of that same 5% over the course of radiotherapy. And in this study, weight data was only collected for the period of radiotherapy. This is the measure we use for us looking at risk of malnutrition, the 5% over the course of the treatment. And that's also enabled comparison to other studies that have been carried out. The weight data was recorded in a separate form from the one that Amy just shared with us. This allowed eyeballing of trends in weight change and further investigation where required. What we did notice there were a number of recordings taken where patients demonstrated a large increase in weight, over the order of about 4 or 5 kilograms over the course of a week. These are then identified as being weight measurements that were taken after chemotherapy being administered and they were therefore artificially elevated. So once we've gone through all these, we were able to eliminate these kind of measurements, but we did maintain the rest of the data for those patients. So the basic data we've got first of all, the range of weight loss for these patients was from a kilogram gained to 30.4 kilograms lost, which is equivalent to 1.8% of starting body weight gain to 2.9% lost. The mean weight loss was 5 kilograms or 6.1% of body weight. It broke down so that 3 patients gained weight throughout their treatment, 13 lost up to 5%, further 18 between 5 and 10%, and the final 6 lost more than 10% of their body weight. And in total, that's 24 of the patients of the 40 who lost more than 5% of the body weight and are at risk of malnutrition. So we did the first time analysis to basically see if we could find which variables were associated with weight loss. They were all compared individually first of all with both absolute and percentage weight loss. We did get several variables from doing this. They were younger age, younger patients showing increased weight loss, primary tumour stages 1 and 2, higher end stage, and patients who received both induction and concurrent chemotherapy as part of the treatment all had a trend for more weight loss. Additionally to this, patients with a higher starting body weight were associated with absolute weight loss but not relative weight loss. The secondary analysis then controlled those variables to see which ones then remained predictive and significant. And the ones that turned out to be significant were age and nodal stage. And the relationships were again strongest for relative weight loss as a percentage measure rather than absolute as a measure of kilograms of weight. In the data on the graphs on the screen, there are what appear to be a couple of anomalies. So the graph on the left, the age one first of all, that plots age against weight loss. On the left hand side of that, there are 2 plots where there are 2 patients much younger than the rest of the cohort. These were 17 and 28. And they were compared to the mean age in the cohort 57 and the next youngest in the cohort being 43. They both also demonstrated weight loss of greater than 10% of their starting body weight. So this was basically checked now to see if there was any undue influence to see if they were outliers having a large effect on the relationship. Various tests were done and the analysis was rerun without both these patients, but it didn't have any effect. What difference there were remained insignificant. On the graph on the right hand side, that plots your mean weight loss by nodal stage. On the end now we've got nodal stage 3, which has a relatively low weight loss compared to stage 1 and 2, but there was only 1 patient in this group. So again, it didn't really have a great influence, and it's just kind of there on its own. But just for the clarity, the breakdown for nodal stage, there were 13 patients who were in N0, 6 who were M1, 18 who were M2, and the 2 others who were unknown and excluded from that part of the analysis. So what we found, weight loss is common amongst head and neck cancer patients undergoing radiotherapy. Not everyone will experience weight loss, and many do. As stated earlier, this can be as part of symptomatic of the disease or related to treatment interventions. The table here is just a collection of various studies that have also done civil investigation and demonstrates a whole range of variables have been discovered to have some sort of association with weight loss in various cohorts. But the variables are not necessarily easily repeated between the different studies. This could be due to differences in the overall aims of studies, things such as looking for the cause of weight loss, as opposed to what we were doing, which was looking to identify predictive factors but not necessarily causative factors. As well, it could be as much down to being the complexity of the phenomenon of weight loss. So, in this study, the mean weight loss across the cohort was similar to that reported in other studies, although it was at the top end of the range. However, 60% of patients had severe weight loss, i.e. above 5% of their body weight, indicating malnutrition. This is generally higher than has been reported in other studies at the end of radiotherapy. The final weight measurements in our study were again taken during the last week of radiotherapy, and whereas other studies had followed up patients beyond completion of radiotherapy, which will note weight loss does continue to progress, in some cases up to 5 or 6 months after treatment has finished. Other factors that have been found to be significant elsewhere include concurrent chemoradiotherapy and radiotherapy doses above 60 gray. And these are quite common amongst some of the other studies, and these have both been associated with increased weight loss. Standard explanation for this sort of thing is that the higher doses and combined modality treatments are increasing the severity of side effects. This is leading to reduced oral intake and therefore increased weight loss. However, in a cohort of stage 1 and 2 laryngeal patients studied by Langus et al., none of these patients received chemotherapy, yet they still showed proportionally similar weight loss, so it is not all about toxicity. So again, in this study, we had age and predictive factor. This particularly younger age has appeared to show up in other studies. It's been a similar trend. Sometimes it's been predictive, other times it's not, and some further studies not identified a relationship at all. I only came across the one study that investigated psychological factors. This shows the presence of depression, as indicated by self-report questionnaires at the beginning of radiotherapy, to be predictive of weight loss. And this is interesting because depression is considered to be potentially a modifiable and treatable condition, and therefore effective management of psychological factors may often be avenues for intervention. However, the lack of study in this area also suggests that depression, other psychological influences, is an aspect of cancer care that's not being fully addressed at the moment. So again, the study that are influential variable we had was nodal status. Again, high nodal status predicting for higher weight loss. Again, in the study by Langus et al., they noticed that irradiation of neck nodes was the most reliable predictive factor. And that's in comparison with the study by Malnutrition et al., who also found that larger PTVs were predictive. And they kind of put them all two together, simply inclusion of neck nodes within the PTV, within the treatment field, giving a larger PTV. And we can expect this to increase the extent of side effects, again, limiting oral nutritional intake, leading on to malnutrition. In this study, we found that T stage was negatively correlated with weight loss, whereas common across other studies has been, if cancer stage is related, as stage goes up, so does weight loss. Again, this is more intuitive, the expected impact of more advanced disease requiring larger PTVs, again, increasing toxicity. However, maybe this is something to do with the when patients are managed, i.e. those with more advanced disease are recognised as being at risk earlier on. And moving on to enteral feeding. No consensus on this subject really, both evidence for positive and negative outcomes. At Western Park, prophylactic pegs are offered to patients who undergo, or due to undergo concurrent chemoradiotherapy. There is evidence to show that enteral feeding helps prevent malnutrition, and this has been demonstrated in several studies. However, on the flip side, enteral feeding has also been linked with increased dysphagia, potentially explained by reduced exercise as well as the muscular. People who have these peg genes are more likely to go for them earlier, stop eating earlier, and it is having a long-term impact on kind of quality of life and their ability to eat after treatment has been completed. So more robust study of weight loss can provide opportunity to develop clinical models for predicting weight loss and malnutrition. We have shown with a relatively small sample that you can identify patients with certain characteristics. So with a larger cohort and more in-depth analysis, you can maybe create a model that's going to predict your patients, identify them earlier, so you can start putting forward interventions that can help them. Now, trying to predict how much weight any one individual will lose would be difficult. But if patients could be categorised, for example, based on risk level, then a more tailored care package could be potentially put together, as well as providing reference to how individuals are progressing and how effective their care package is. So my final bit then, so to conclude, like I said, 60% of patients lost more than 5% of their body weight at the start of radiotherapy, and this was over a period of 6 to 7 weeks. Younger patients living with no disease are more at risk of weight loss. Now these same factors have been identified in some studies, but not in others. Again, large studies have also found other factors to be influential, including but not limited to things like site of primary, radiotherapy dose, or performance status. The relative importance of the various factors is not yet known, and nor is the best way of identifying patients most at risk of weight loss or malnutrition. But as I said just a moment ago, further study has potential to clarify the situation, provide clinically useful information, and also evaluate how effective different interventions can be. And so finally, as a little addition there, this study is also supplementing further work being carried out by Amy and Rosie at Western Park, which is asking, based on side effects and their timings, whether the current protocol is providing patients undergoing rapid out treatment with appropriate dietetic care and support throughout their radiotherapy treatment.
So thank you to Patrick for agreeing to be part of tonight's webinar, and we'd like to thank Sheffield Teaching Hospitals as well for giving us permission to carry out the work. And again, thank you to JRP for inviting us to present, so thank you very much. So if you've got any questions, please post to Heidi and we'll have some discussion. Thank you.
Thanks, Amy. Thanks, Patrick. Amy, should I just ask you just to switch your... thank you, I think you've switched your audio off already. I'd just like to thank both authors for their very comprehensive presentation of their work today. It was really, really interesting. I've got a load of questions that I'd like to ask myself. I've got one from Professor Duxbury, actually, which I'll ask first, which is in relation to nutritional interventions for this group of patients. So what do the authors see as the role of nutritional interventions for the management of these patients in the future? Over to you.
Thank you for your question. Well, it kind of, over the past couple of years, we've noticed that the kind of dietetic regimes are developing in department, and instead of it being a let's wait and see how much weight patients lose and then refer them on, it is very much becoming, picking them up at the beginning of the treatment, be it just a dietetic support assistant kind of position where they're weighing them and just having general dietetic advice, to seeing them on a weekly basis, and it being used in combination with their clinic and radiographer-led review. So it is becoming kind of more routine for these patients. I think it's important that especially the ones that we are identifying that are classed as being predictive from the findings of this study, so the younger patients especially, are identified early on within their treatment that these are possibly at higher risk. Again, it's that tailoring the management approach to it. So identifying what if there's anything kind of their lifestyle specific as well in addition to it. So is there a reason why those younger patients maybe are losing more weight? Are they following kind of a different protocol or lifestyle experience, which is meaning that they're not kind of keeping their nutritional value up as well? Is there anything that you want to add?
I would just add further on to the idea of addressing psychological factors. So, for example, with younger patients, are they finding it hard to deal with the diagnosis? Do they have other pressures in their lives that make it hard to look after themselves as well as the people around them? So this kind of, not so much a nutritional intervention, but this sort of intervention, finding out what's happening with these people and how to make that better, may then permit them to look after themselves better and follow the nutritional advice they're given, look after themselves and minimise the weight loss.
So it's more of a kind of holistic supportive role as well, in addition to not just the dietetic side of it. So, yeah. Thank you. Any more?
Yeah, I've got some questions, Amy and Patrick. Just in relation to within nutrition, and you talked about the role of enteral feeding. So how many of the patients that you studied in your audit had enteral feeding? Hi, Amy, are you having trouble getting your... Yes, I did ask that, yeah.
So it's just, sorry, it's very kind of quiet this side. So you said how many had pegs? Yeah.
In this cohort, there was 25 who had prophylactic pegs. I believe there's a further one who had a nasogastric tube inserted partway through treatment.
Yeah, patients are standard undergoing chemoradiotherapy get offered a prophylactic peg. It is obviously only offered to them, and some patients do refuse. Sometimes it is kind of, again, anecdotally about these patients who do refuse, then having to try and we have like kind of significant problems with these patients during, and sometimes we will have a peg fitted partway through the treatment, which obviously has problems with missing appointments, breaks in treatment, and kind of by that point there's a higher risk of them being malnourished and dehydrated, so there's other kind of complications associated with undertaking that surgery.
Thanks, Amy. I've got a few other questions. I couldn't remember, I didn't get long enough on the slide that shows the variables that had the highest association with weight loss. So apart from age and nodal status, which were significant in your regression analysis, was the site or the type, the diagnosis of the head and neck cancer, oh, you're going back for me, lovely. Was that a factor in whether, so for example, was it anything, was there an association between whether they were nasopharynx or an oropharynx? Oh, here we go. Okay, so no. So was that something that you looked at and measured whether the size of the original tumour? And I think in your discussion you talked about the other studies that have shown the size of the PTB. Was that something that you measured, and was that a significant variable?
So can you, yeah, that's it, thank you.
So yeah, we had a look at the site of the primary tumour, but the problem with the sample size was too small, and there was quite a spread of initial primary sites, so there wasn't enough data to give that proper analysis. Looking at other studies, the common ones are oropharyngeal and oral cavity. That's the site that comes up most often as being linked with increased weight loss. And the flip side of that is often it's laryngeal cancers that show the lowest amount of weight loss. But again, this is almost an oversimplification. Like when looking at the study, it was just all laryngeal patients. They were showing as much weight loss as any other site. So when you get a large population and large sampling, there certainly seems to be something that can be identified there. But how much of an influence that's actually having is then another question that seems to be quite hard to decide.
What I should have said earlier as well is when we were outlining what characteristics we wanted to look at, we had an agreement that there had to be 3/4 of the patients with that kind of specific information recorded as part of the notes in order to be able to do the analysis, because it was such a small sample size. So there were some things that we did note wasn't actually identified in the patient's notes. So just to add on to that.
Thank you. I've got another couple of questions. So you talked about the sample size, which is 40. How did you decide on 40? What the rationale for selecting a sample size of 40. And the second question, I'll ask it now so that I can switch off and listen. And the second question is from Mark. Did any of the patients need replanning as a result of their weight loss?
Sorry, I heard the first part of the question, so I'll answer that one, but I need to repeat the second one. The security man came in to see what we're up to. We originally had, as part of the bigger study, we had the data from around 90 patients. We've got this data because the planning department was looking at moving to thermoplastic, to orphic shells from thermoplastic, and so they recorded kind of patient data, the primary site, things like this, and so we were able to use some of this data to start give us like an identifiable group. It ended up being, we were originally looking at 50 patients, but we were noticing that there was quite a few that didn't have comprehensive notes recorded. All the notes had gone to other departments for kind of other treatments and follow-ups and clinics, and then it just ended up being 40 patients for kind of convenience really, as it was completed as part of Patrick's dissertation process. We were kind of under a limited timeline to get it done, so it was kind of pure convenience that we ended up with 40. I'll have to ask what the second part of the question is.
Okay, so the second part of the question is Mark's question, and he wanted to know, did any of the patients require a replan because of their weight loss?
So no, none of the patients requires replanning. It's not something that's generally done as standard practice. Within department, they will try and correct for as a first kind of incident, first action, and then it would be if it was having a kind of volumetric impact greater than 2%, then we would look at replanning, but no, none of the patients that we had.
The replanning thing would be quite interesting though. Again, that gives you another endpoint to look at, so you could take the patients that did need a replan and those that didn't, and see if you can identify a difference between them. That again could help to identify risk factors for when these patients work in the department, but actually I didn't actually come across any in the sample used.
What we are going to do with the data from this is look at kind of a bigger project to it. So the same patients that we use to identify the predictive factors, we're going to be using to look at if the weight loss and the delta corrections did correlate. So we will be able to see, you know, the ones that were losing more weight, did this have kind of a significant influence on you know, with the contour, we'll be having to correct a lot more for these daily variances, and then again these patients will then be compared to look at is there an issue that would have required replanning. So should this have been done, you know, obviously retrospectively looking at this data. So it's once we've kind of got this all combined and the results from the other work that we're doing, we can kind of give a bit more of a comprehensive discussion about whether, you know, whether these patients would require replanning.
Okay, thanks Amy. I've just got another couple of questions. I'll just wait for anybody else to type away. You talked a lot about the key variables being, one of the key variables being younger age. What is a younger age? What age range are you talking about when you talk about younger?
So because we wasn't actually building a model to predict which, to make the predictions later on, I didn't do any analysis as to what age would be the cutoff. It was just generally the trend, which I think was best demonstrated on the graph really, that obviously there's quite a spread, but you could see a line of best fit, if we go to the next page, that generally the weight is going up towards the left hand, towards the younger patients. I wouldn't like to just kind of pick a point on that graph to segregate the two. In other studies, where they have gone on to then developing a model, the age split seems to come around 60, 65 years old, and those being that sort of age are the ones that are being identified as being having greater weight loss.
Thanks, Patrick. So I think it's something that you mentioned earlier when you were talking about psychological determinants of weight loss as being an interesting area. Sorry, I'm just going to adjust my microphone so you can hear me a bit better. So in terms of looking at this graph where there is an inverse correlation, or appears to be an inverse correlation between weight loss and age, I think what an interesting factor for future studies might be something that you mentioned, which was how perhaps those younger patients are managing on their own, and whether it's a factor that they don't have help at home to support them in terms of managing with their diagnosis, but also managing their eating. And you know, when you have a poor appetite, you don't necessarily want to cook or feed yourself. So I think you're right. I think that might be an interesting area for future research. I've got another question here. Do the authors have a view on psychological interventions for head and neck patients and prevention of weight loss? What are your views on that?
So, brief silence access to them, not exactly experts in this area, but yeah, largely an unexplored area really. Possibly because we are used to seeing patients coming through of a certain age, sort of the cancer age, but you don't really see that impact. So it's only when you get the younger patients coming through, you tend to take note more of the psychological impact and the issues they may be facing. But I think it comes down to things like the family support you've got around, if there is someone at home with you, if there isn't, and how they're supporting you, how they're dealing with it. These all would be things that can basically impact on someone's well-being and how well they're looking after themselves. And the two youngest patients in this, when I saw the weight, I kind of looked further into their details, see if there were extenuating circumstances as to why their weight loss did seem so high. And they weren't your average patient. As well as being younger, there were other things going on in their lives that kind of made them stand out a bit. We again contribute to this idea of how well were they able to cope. And certainly the youngest ones, to be at the age of 17 and getting a diagnosis of cancer, a lot to cope with and deal with there. So something that could certainly be looked at and may require certainly quite specialist intervention probably outside of the radiotherapy department.
It's only kind of an observation really from my point of view as well for the patients that we are noticing that getting diagnosed younger because of the HPV related squamous cells rather than your standard kind of etiological factors. There's kind of, for me, I wonder whether there's some psychological element to that, what it's generally associated with as well. And there's a lot of issues and obviously the research that's going off around this, and we're finding that the consultants are having some difficult conversations with the patients regarding other kind of behaviours that these patients kind of involved with. So this kind of that psychosocial side of it as well, which would be worth investigating, whether that's got an impact.
Thanks, Amy, and thanks, Patrick. Angela's got another question. Should head and neck patients be given weight-gaining therapies before treatment as a preemptive approach to reducing the weight loss during treatment? What are your thoughts on that?
So it's kind of a different Yeah, it's kind of a difficult one to answer because there was some kind of association between the starting weight and higher body weight. Obviously, it wasn't positively correlated, but also it's how the kind of patient manages that as well. Are they going to be able to follow the kind of dietetic instruction prior to starting treatment? How long is this going to, be required before we start treatment? And would it delay the start date? Because obviously that's something that we need to consider for kind of the radiobiology side of these cancers. Have you got any?
I think this sort of feeds into the idea of where you've got patients who, as part of their disease presentation, they've already lost weight. So if they've got a history of several months or several weeks of weight loss, you could certainly argue that's likely to continue. So these patients, there seems to be possibly a potential there, something to be investigated to whether if they can have any weight gain therapy, if that's actually going to get them to put on weight or stop the weight loss before treatment begins, and then whether or not that will then be maintained throughout the treatment later on as well. But it's not something I came across any research that I've been looked into when I was doing this project.
Thanks Amy, thanks Patrick. Is there any last questions from the floor before we call it a night, unless our presenters have a well-earned rest? I'm just having a look to see if anybody's typing yet. It doesn't look like there's any further questions, so I'd just like to call this webinar to a close and thank our speakers again for their presentations, taking the time to present their work. It's a really interesting piece of work, Amy and Patrick, and I know it's part of a bigger piece of research. And I wish you luck with the future study that you're doing, and hope that goes well and that you'll be able to come back and report to us on how the bigger study has developed. Once again, I'd just like to thank everybody for attending as well, our first webinar. The recording will be available. There will be a link probably sent out to everybody in case you were late coming or you couldn't hear some aspects of the presentation. But thank you for joining us. I hope that you will join us in our next series of webinars. We hope to have at least another one in November this year. A bit of an advert for our research seminar series. If you are close to Sheffield, or if you know anybody that's close to Sheffield, we run face-to-face research seminar series here at Sheffield Hallam. And our next one at the beginning of November, on Friday the 6th of November, is on prostate brachytherapy. So it's free to attend. You just need to register with my colleague Jo Dawson. Her email is at the bottom there. It's j.p.dawson@shu.ac.uk, or you can just turn up, it's fine. But for numbers it does help us. And we start at 8:30 with coffee and cake, and a 9 o'clock start. So hopefully we might see some of you there. So I'd just like to say thank you again to our speakers, Patrick and Amy. I'm going to say good night, and thank you for joining us. Good night.